Hello everyone, and welcome back to another chapter of Advanced Pharmacology. Today we're talking about Chapter 31, Drug Abuse and Alcohol. So, jumping in on alcohol. Alcohol, also known as ethyl alcohol or ethanol, is the most commonly used and abused psychoactive agent in the United States and most likely worldwide. Although alcohol does have some therapeutic applications, the drug is of interest primarily for its non-medical use. When consumed in moderation, alcohol prolongs life and reduces the risk for dementia and cardiovascular disorders. Conversely, when consumed in excess, alcohol diminishes life in both quality and quantity. In approaching our study of alcohol, we begin by discussing the basic pharmacology of alcohol, and then we discuss alcohol use disorder and the drugs employed for treatment. So, we'll jump right into the basic pharmacology of alcohol. The central nervous system, its acute effects. Alcohol has two acute effects on the brain: general depression of the central nervous system, its function, and the activation of the reward circuit. For many years, we believed that alcohol simply dissolved in the neuronal membrane, thereby disrupting the order of arrangement of membrane phospholipids. However, we now know that alcohol interacts with specific proteins, certain receptors, ion channels, and enzymes that regulate neuronal excitability. Three target proteins are the particular importance, namely receptors for gamma-aminobutyric acid, so your GABA, receptors for glutamate, and the 5-HT3 subset of receptors for serotonin. The depressant effect of alcohol results from binding with receptors for GABA and receptors for glutamate. When alcohol binds with GABA receptors, it enhances GABA-mediated inhibition, causing a widespread depression of CNS activity. When alcohol binds with glutamate receptors, it blocks glutamate-mediated excitation and therefore reduces the overall CNS activity. The rewarding effects of alcohol result from binding with the 5-HT3 receptors in the brain's reward circuit. When the receptors are activated, they promote release of dopamine, the major neurotransmitter of the reward system. When alcohol binds with these receptors, it enhances serotonin-mediated release of dopamine and intensifies the reward process. The depressant effects of alcohol are dose-dependent. When dosage is low, higher brain centers are primarily affected. As dosage increases, more primitive brain areas become depressed. Within depression of cortical function, thought processes and learned behaviors are altered. Inhibitions are released and self-restraint is placed by increasing sociability and expansiveness. Cortical depression also impairs motor function. As CNS depression deepens, reflexes diminish greatly and consciousness becomes impaired. At very high doses, alcohol produces a state of general anesthesia. So, its chronic effects. When consumed chronically and in excess, alcohol can produce severe neurologic and psychiatric disorders. Injury to the CNS is caused by the direct actions of alcohol and by the nutritional deficiencies often seen in chronic heavy drinkers. Two neuropsychiatric syndromes are common in alcoholics: Wernicke's encephalopathy and Korsakoff's psychosis. Both disorders are caused by thiamine deficiency, which result from poor diet and alcohol-induced suppression of thiamine absorption. Wernicke's encephalopathy is characterized by confusion, nystagmus, and abnormal ocular movement. This syndrome is readily reversible with thiamine. Korsakoff's psychosis is characterized by the polyneuropathy, inability to convert short-term memory into long-term memory, and confabulation. Korsakoff psychosis is not reversible. Perhaps the most dramatic effect of long-term excessive alcohol consumption is the enlargement of the cerebral ventricles, presumably in response to atrophy of the cerebrum. These gross anatomic changes are associated with impairment of memory and intellectual function. With cessation of drinking, ventricular enlargement and cognitive deficits partially reverse, but only in some individuals. So, impact on the cognitive function. Low to moderate drinking helps preserve cognitive function in older people and may protect against developing of dementia. Its effect on sleep. Although alcohol is commonly used as a sleep aid, it actually disrupts sleep. Drinking can alter sleep cycles, decrease total sleeping time, and reduce the quality of sleep. In addition, alcohol can intensify snoring and exacerbate obstructive sleep apnea. It also has some other pharmacologic effects on the cardiovascular system. When alcohol is consumed acutely and in moderate doses, cardiovascular effects are considered minor. The most prominent effect is the dilation of cutaneous blood vessels, causing increased blood flow to the skin. By doing so, alcohol imparts a sensation of warmth, but that at the same time promotes the loss of heat. Although the cardiovascular effects of moderate alcohol consumption are unremarkable, chronic and excessive consumption is clearly harmful. Abuse of alcohol results in direct damage to the myocardium, thereby increasing the risk for heart failure. Some investigators believe that alcohol may be a major cause of cardiomyopathy in the Western world. In addition to damaging the heart, alcohol produces a dose-dependent elevation of blood pressure. The cause of vasoconstriction in vascular beds of skeletal muscle brought on by the increased activity of the sympathetic nervous system, estimates suggest that heavy drinking may be responsible for 10% of all cases of hypertension. Not all of the cardiovascular effects of alcohol are deleterious. There is clear evidence that people who drink moderately experience less ischemic strokes, coronary artery disease, myocardial infarction, and heart failure than do abstainers. It is important to note, however, that heavy drinking increases the risk for heart disease and stroke. Moderate drinking protects against heart disease primarily by raising levels of high-density lipoprotein cholesterol. As discussed in Chapter 42, your HDL cholesterol protects against coronary artery disease, whereas your LDL cholesterol promotes coronary artery disease. Of all the agents that can raise HDL cholesterol, alcohol is one of the most effectively known. In addition to raising HDL cholesterol, alcohol may confer protection through four other mechanisms: by decreasing platelet aggregation, decreasing levels of fibrinogen, increasing levels of tissue plasminogen activators, and by suppressing the inflammatory component of atherosclerosis. The degree of cardiovascular protection is nearly equal to or equal for all beers, wines, and distilled spirits. That is, protection is determined primarily by the amount of alcohol consumed, not by the particular beverage the alcohol is in. Also, the pattern of drinking matters. Protection is greater for people who drink moderately, 3 or 4 days a week, than for people who drink just 1 or 2 days a week. Finally, cardioprotection is greatest for those with an unhealthy lifestyle. Among people who exercise, eat fruits and vegetables, and do not smoke, alcohol has little or no effect on the incidence of coronary events. Conversely, among people who lack these behaviors, moderate alcohol intake is associated with a 50% reduction in coronary risk. Glucose metabolism. Alcohol has several effects on glucose metabolism that may decrease the risk for type 2 diabetes. So another example, alcohol raises levels of adiponectin, a compound that enhances insulin sensitivity. In addition, alcohol suppresses gluconeogenesis, blunts the postprandial rise in blood glucose, and lowers the fasting levels of both glucose and insulin. Bone health. Alcohol increases bone mineral density, probably by increasing levels of sex hormones. Respiration. Like all other CNS depressants, alcohol depresses respiration. Respiratory depression from moderate drinking is negligible. However, when consumed in excess, alcohol can cause death by respiratory arrest. The respiratory depressant effects of alcohol are potentiated by other CNS depressants. The liver. Alcohol-induced liver damage can progress from fatty liver to hepatitis, to finally cirrhosis, depending on the amount of consumed alcohol. Acute drinking causes reversible accumulation of fat and protein in the liver. With more chronic drinking, non-viral hepatitis develops in about 90% of heavy users. In 8 to 20% of chronic alcoholics, hepatitis evolves into cirrhosis, a condition characterized by the proliferation of fibrous tissue and the destruction of liver parenchymal cells. Although various factors other than alcohol can cause cirrhosis, alcohol abuse is unquestionably the major cause of fatal cirrhosis. The stomach. Excessive use of alcohol can cause erosive gastritis. Again, about one-third of alcoholics have this disorder. Two mechanisms which are involved. The first, alcohol stimulates the secretion of gastric acid, and the second, when present in high concentrations, alcohol can injure the gastric mucosa directly. The kidneys. Alcohol is a diuretic, so it promotes urine formation by inhibiting the release of antidiuretic hormone, or ADH, from the pituitary gland. Because ADH acts on the kidney to promote water reabsorption, thereby decreasing urine formation, a reduction in circulating ADH will increase urine production. The pancreas. About 35% of cases of acute pancreatitis can be attributed to alcohol, making alcohol the second most common cause for the disorder. Flare-ups typically occur after a bout of heavy drinking. Only 5% of alcoholics develop pancreatitis, and then only after years of overindulgence. Sexual function. Alcohol has both physiologic and psychologic effects related to human sexual behavior. Although alcohol is not exactly an aphrodisiac, its ability to release inhibitions has been known to motivate sexual activity. Ironically, the physiologic effects of alcohol may frustrate attempts at consummating the activity that alcohol inspires. Objective measurements in male and female show that alcohol significantly decreases our physiologic capacity for sexual responsiveness. In males, long-term use of alcohol may induce feminization. Symptoms include testicular atrophy, impotence, sterility, and breast enlargement. Cancer. Alcohol, even in moderate amounts, is associated with an increased risk for several common cancers. Among these are cancers of the breast, liver, rectum, and aerodigestive tract, which include the lips, tongue, mouth, nose, throat, vocal cords, and portions of the esophagus and trachea. According to a 2011 study, alcohol causes 10% of all cancers in men and 3% of cancers in women. The fraction attributable to alcohol is highest for the aerodigestive tract cancers, somewhat lower for liver cancers, and even lower for colorectal cancers, and the lowest for breast cancer in women. Data suggest that regarding cancer risk, no amount of alcohol can be considered safe, although risk is lowest with moderate drinking. Pregnancy. Effects of alcohol on the developing fetus are dose-dependent. Risk for fetal injury is greatest with heavy drinking, and much lower with light drinking. Is there some level of drinking that is completely safe? Well, technically we don't know. Fetal alcohol exposure can cause structural and functional abnormalities, ranging from the mild neurobehavioral deficits to facial malformations and developmental delay. The term fetal alcohol spectrum disorder, or FASD, is used in reference to the full range of outcomes, from mild to severe, that drinking during pregnancy can cause. In contrast, the term fetal alcohol syndrome, or FAS, is reserved for the most severe cases of FASD, characterized by the craniofacial malformations, growth restrictions, and neurodevelopmental abilities, manifesting during childhood as cognitive and social dysfunctions. In addition to causing FASD and FAS, heavy drinking during pregnancy can result in stillbirth, spontaneous abortions, and giving birth to an alcohol-dependent infant. So, is light drinking safe during pregnancy? The data is unclear. Two studies established in 2010 suggest that light drinking may carry very little risk. One study conducted in the UK found that no clinically relevant behavioral or cognitive problems in 5-year-olds whose mothers consumed 1 to 2 drinks a week during pregnancy. The other study conducted in Australia found no link between low to moderate alcohol consumption during pregnancy and alcohol-related birth defects. Although the same study did show that heavy drinking was associated with a fourfold increased risk for the ARBD, or alcohol-related birth defect. These results are consistent with other recent studies, which have failed to show a relationship between the occasional or light drinking during pregnancy and the abnormalities in newborns or older children. Again, because all of these studies were observational rather than randomized controlled trials, the negative result might be explained by confounding factors, especially education level, income, or access to prenatal care. Furthermore, because the follow-up time for these studies was relatively short, only 5 years, the long-term effects of light drinking still remain unknown. If there is amount of alcohol that is safe during pregnancy, the amount is very low. Accordingly, despite the studies noted previously, the American College of Obstetricians and Gynecologists and the American Academy of Pediatrics continue to maintain the long-held position that no amount of alcohol can be considered safe during pregnancy. Therefore, in the interest of fetal health, all women should be advised to avoid alcohol entirely while pregnant or trying to conceive. Having said that, it is important to appreciate that a few drinks early in pregnancy are not likely to harm the fetus. Consequently, if a woman consumed a little alcohol before realizing she was pregnant, she should be reassured that the risk to the fetus, if any, is considered extremely low. Which brings us to lactation. The concentration of alcohol in breast milk parallels the concentration in blood, so recent data indicates that drinking while breastfeeding can adversely affect the infant's feeding and behavior. The impact on longevity. The effects of alcohol on the lifespan depend on the amount consumed. Heavy drinkers have a higher mortality rate than the population at large. Causes of death include cirrhosis, respiratory disease, cancers, and fatal accidents. The risk for mortality associated with alcohol abuse increases markedly in individuals who consume 6 or more drinks a day. Interestingly enough, people who consume moderate amounts of alcohol live longer than those who abstain. And combining regular exercise with moderate drinking prolongs life even more. Compared with a non-drinker, moderate drinkers have a 30% lower mortality rate and a 50% lower incidence of a myocardial infarction and a 59% lower incidence of heart failure. According to the study by the American Medical Association, if all Americans were to give up drinking, death from heart disease would increase by 81,000 patients a year. Therefore, people who are already moderate drinkers, continued moderate drinking would seem beneficial. Conversely, despite the apparent benefits of drinking and the apparent health disadvantage of abstinence, no one is recommended that abstiners take up drinking. Furthermore, when the risk of alcohol outweighs any possible benefit, such as in pregnancy, then alcohol consumption should be avoided entirely. So now we can speak on the pharmacokinetics, its absorption. Alcohol is absorbed from the stomach and small intestine. About 20% of ingested alcohol is absorbed from the stomach. Gastric absorption is relatively slow and is delayed even further by the presence of food. Absorption from the small intestine is rapid and largely independent of food. About 80% of ingested alcohol is absorbed from the site. Because most alcohol is absorbed from the small intestine, gastric emptying time is a major determinant of individual variation of alcohol absorption. So, its distribution. Because alcohol is both non-ionic and water-soluble, it distributes well to all tissues of body fluids. The drug crosses the blood-brain barrier with ease, allowing alcohol in the brain to equilibrate rapidly with alcohol in the blood. Alcohol also crosses the placenta and therefore can affect the developing fetus. Distribution in body water partly explains why women are more sensitive to alcohol than men. So as a rule, women have a lower percentage of body water than men. Therefore, when a woman drinks, the alcohol is diluted in a smaller volume of water, causing the concentration of alcohol in tissues and fluids to be relatively higher, which causes the effects of alcohol to be more intense. Its metabolism. Alcohol is metabolized in both the liver and the stomach. The liver is the primary site. The process begins with conversion of alcohol to acetaldehyde, a reaction that catalyzed by alcohol dehydrogenase. This reaction is slow and puts a limit on the rate at which alcohol can be inactivated. When formed, acetaldehyde undergoes rapid conversion of aldehyde dehydrogenase to acetic acid. Through a series of reactions, acetic acid is then used to synthesize cholesterol, fatty acids, and other compounds. The kinetics of alcohol consumption differ from those of most other drugs. With most drugs, as plasma drug levels rise, the amount of drug metabolized per unit of time also increases. This, however, is not true for alcohol. As the alcohol content of the blood increases, there is almost no change in the speed of alcohol breakdown, which means alcohol is metabolized at a relatively constant rate, regardless of how much alcohol is present. The average rate at which an individual can metabolize alcohol is about 15 ml per hour, or half an ounce. Because alcohol is metabolized at a slow and constant rate, there is a limit to how much alcohol one can consume without having a drug accumulate. For practical purposes, the limit is about 1 drink per hour. Consumption of more than 1 drink per hour, be that drink beer, wine, straight whiskey, or a cocktail, will result in alcohol accumulation. When used on a regular basis, alcohol-induced hepatic drug metabolizing enzymes thereby increase the rate of its own metabolism and that of other drugs. As a result, individuals who consume alcohol routinely in high amounts can metabolize the drug faster than people who drink occasionally and moderately. Your males and females differ with respect to activity of alcohol dehydrogenase in the stomach. Specifically, women have a lower activity limit, so as a result, gastric metabolism of alcohol is significantly less in women. This difference partly explains why women achieve higher blood alcohol levels than men after consuming the same number of drinks. Which brings us to the tolerance. Chronic consumption of alcohol produces tolerance, so as a result, to alter consciousness, people who drink on a regular basis require larger amounts of alcohol than people who drink occasionally. Tolerance to alcohol confers cross-tolerance to general anesthetics, barbiturates, and other general CNS depressants. However, no cross-tolerance develops to opioids. Tolerance subsides within a few weeks after drinking cessation. Although tolerance develops to many of the effects of alcohol, very little tolerance develops to respiratory depression. Consequently, the lethal dose of alcohol for chronic heavy drinkers is not much bigger than the lethal dose for a non-drinker. Alcoholics may tolerate blood alcohol levels as high as 0.4%, with no marked reduction in consciousness. However, if the blood levels rise only slightly above this level, death may ensue. Bringing us to the physical dependence. Chronic use of alcohol produces physical dependence. If alcohol is withdrawn abruptly, an abstinence syndrome will result. The intensity of the abstinence syndrome is proportional to the degree of physical dependence. Individuals who are physically dependent on alcohol show cross-dependence with other general CNS depressants, your barbiturates, chloral hydrate, benzodiazepines, but not with opioids. So drug interactions. Again, your CNS depressants. The CNS effect of alcohol are addictive with those of other CNS depressants. Consumption of alcohol with other CNS depressants intensifies the physiologic and psychologic manifestations of CNS depression and greatly increase the risk for death from respiratory depression. Your nonsteroidal anti-inflammatory drugs. Similar to alcohol, aspirin, ibuprofen, and other NSAIDs can injure the gastrointestinal mucosa. The combined effects of alcohol and NSAIDs can result in significant gastric bleeding. Tylenol. The combination of Tylenol with alcohol poses a risk for potentially fatal liver injury. The interaction between alcohol and Tylenol will be discussed in further detail in Chapter 55. Disulfiram. The combination of alcohol with disulfiram, or antabuse, can cause a variety of adverse effects, some of which are dangerous. These effects and the use of disulfiram to maintain abstinence will be discussed later in this chapter. Your antihypertensive drugs. Alcohol raises blood pressure. It tends to counteract the effects of antihypertensive medications. However, elevation of blood pressure is significant only when alcohol dosage is high. Conversely, when the dosage is low, alcohol may actually help. Among hypertensive men, light to moderate alcohol consumption is associated with a reduced risk for both cardiovascular mortality and all-cause mortality. Your acute overdose. Acute overdose produces vomiting, coma, pronounced hypotension, and respiratory depression. The combination of vomiting and unconsciousness can result in aspiration, which in turn can result in pulmonary obstruction and pneumonia. Alcohol-induced hypotension results from a direct effect on peripheral blood vessels and cannot be corrected with vasoconstrictors. Hypotension can lead to renal failure and cardiovascular shock, a common cause of alcohol-related death. Although death can result from respiratory depression, this is not the usual cause. Because symptoms of alcohol poisoning can mimic symptoms of other pathologies, a definitive diagnosis may not be possible without measuring alcohol in the blood, urine, or expired air. The smell of alcohol in the breath is not a reliable means of diagnosis because the breath odors we associate with alcohol are due to impurities in alcoholic beverages and not in alcohol itself. Therefore, these odors may or may not be present. Alcohol poisoning is treated like poisoning with any other general CNS depressant. The details of management will be discussed in Chapter 27. Alcohol can be removed from the body via a gastric lavage and dialysis. Your stimulants, your caffeine, should not be given. So, precautions and contraindications. Alcohol can injure the GI mucosa and should not be consumed by someone who has peptic ulcer disease. Alcohol is harmful to the liver and should not be used by individuals with liver disease. Again, alcohol should be avoided during pregnancy, owing to the risk of FASD, stillbirth, spontaneous abortion, and neurodevelopmental abnormalities. Alcohol must be used with caution by patients with epilepsy. During alcohol use, the CNS is depressed. When alcohol consumption ceases, the CNS undergoes rebound excitation, which could result in a seizure. Again, alcohol causes a dose-related increased risk for breast cancer. All women, and especially those at high risk, should minimize alcohol consumption. Alcohol also increases the risk for cancer of the liver, rectum, and again, the aerodigestive tract. So it's therapeutic use, therefore. Although our emphasis has been on the non-medical use of alcohol, it should be remembered that alcohol does have a therapeutic application. Topically, topical alcohol can be an effective skin disinfectant, and local injection of alcohol in the vicinity of nerve produces a nerve block. This technique can relieve pain from inoperable carcinomas and similar causes. So now we can speak on some alcohol use disorders, also known as alcoholism or alcohol dependence, which is a chronic relapsing disorder characterized by the impaired control over drinking, preoccupation with alcohol consumption, the use of alcohol despite awareness of adverse consequences, and distortions in thinking, especially as evidenced by denial of a drinking problem. The development and manifestation of alcoholism is influenced by genetic, psychosocial, and environmental factors. The disease is progressive and often fatal. In the US, about 8 million adults are considered alcoholics. Alcohol use disorder is defined as a problematic pattern of alcohol use, leading to clinically significant impairment or distress occurring within a 12-month period. Manifestations of alcohol use disorder can include recurrent alcohol use in situations in which it is a physical hazardous recurrent use, resulting in a failure to fulfill major rule obligations at work, school, or home. and spending a great deal of time in activities necessary to obtain alcohol, use alcohol, or recover from alcohol. So here is an excellent spot to hit pause so you can see the patient-centered care across the lifespan regarding alcohol. In the United States, misuse of alcohol is responsible for 6 million non-fatal injuries each year and about 85,000 deaths. Causes of death range from liver disease to automobile wrecks. Fully 45% of all fatal highway crashes are alcohol-related. Among teens, alcohol-related crashes are the leading cause of death. Alcohol also causes industrial accidents, which is responsible for 40% of industrial fatalities. Alcohol abuse is a major public health problem, and its consequences are numerous. Alcoholism produces a psychological derangement, including anxiety, depression, and suicidal ideation. Malnutrition, secondary to inadequate diet and malabsorption, is common. Poor work performance and disruption of family life reflect the social deteriorations suffered by alcoholics. Alcohol abuse during pregnancy can lead to FASD, stillbirth, and spontaneous abortion. Lastly, chronic alcohol abuse is harmful to the body. Again, consequences include liver disease, cardiomyopathy, and brain damage, not to mention injury and death from accidents. In 2008, a National Institute of Alcohol Abuse and Alcoholism updated its document helping patients who drink too much. And there is a clinician's guide that clears concise information on screening, counseling, and treatment of alcohol use disorders. By utilizing this guide, clinicians can help reduce morbidity and mortality among people who drink more than is safe, defined as more than 4 drinks in a day, or 14 in a week for men, or more than 3 drinks for a day or 7 days per week for women. Helping patients involves 4 simple steps. Ask about their alcohol use, assess for alcohol use disorders, including the Alcohol Use Disorders Identification Test, advise and assist, and at follow-up appointments continue to provide support. This process is found in part on 2 lines of evidence. First, we can identify people who misuse alcohol with an easily administered questionnaire, such as audit. Second, for many people, alcohol consumption can be reduced through brief interventions, such as offering feedback and advice about drinking and about the setting goals. Long-term follow-up studies have shown that these simple interventions can decrease hospitalizations and lower mortality rates. The guide is available off the following website. You're welcome to hit pause and take a look. One of the screening instruments for alcohol use disorder test or audit is here as well. So it's an excellent spot to hit pause if you are unfamiliar with the audit test. To help individuals who drink too much, the NIAAA created an interactive website located at Rethinking Drinking. It's another website. Hit pause and take a look. Content includes tools to identify and manage problems in drinking, plus a calculator for determining the alcohol content of various beverages. Drugs for alcohol use disorders. Again, in the US, about 1 million alcoholics seek treatment annually. Although the success rate is discouraging, nearly 50% relapse during the first few months. Treatment should nonetheless be tried. The objective is to modify drinking patterns. Drugs that can help in 2 ways. First, they can facilitate withdrawal, and second, they can help maintain abstinence after withdrawal has been accomplished. So, the drugs used to treat the symptoms of withdrawal. Management of withdrawal depends on the degree of dependence. When dependence is mild, withdrawal can be accomplished on an outpatient basis without drugs. However, when dependence is considered great, withdrawal carries a risk for death. Accordingly, hospitalization and drug therapy are indicated. The goal of management is to minimize symptoms of withdrawal, prevent seizures and delirium tremens, and facilitate transition to a program for maintaining abstinence. So in theory, any drug that has cross-dependence with alcohol should be effective. However, In actual practice, benzodiazepines are the drugs of choice. The benefit of benzodiazepines and other drugs used during withdrawal are shown in the following table. And again, here's an excellent spot to hit pause if you're unfamiliar with different medications we can give during alcohol withdrawal. Again, the big ones would be your benzodiazepines, your beta adrenergic blockers, your central alpha adrenergic agonists, and the anti-epileptic drugs. So we'll speak now on some of the benzodiazepines. Of the drugs used to facilitate alcohol withdrawal, benzodiazepines are the most effective. Furthermore, they are safe for use in both inpatient and outpatient settings. In patients with severe alcohol dependence, your benzodiazepines can stabilize vital signs, reduce symptom intensity, and decrease the risk for seizures and delirium tremens. Although all benzodiazepines are effective, agents with longer half-lives are generally preferred because they provide the greatest protection against seizures, as well as breakthrough symptoms. The benzodiazepines employed most are often chlorodiazepine, Librium, chlorcipate, oxazepam, and lorazepam. Traditionally, benzodiazepines have been administered around the clock on a fixed schedule. However, as-needed administration can be just as effective. So, adjustments to benzodiazepines. Combining a benzodiazepine with another drug may improve withdrawal outcomes. Agents that have been tried include carbamazepine, clonidine, and atenolol and propranolol. Carbamazepine may reduce withdrawal symptoms and the risk for seizures. Clonidine and the beta blocker reduces the autonomic component of withdrawal symptoms. In addition, the beta blockers may improve your vital signs and decrease cravings. It should be stressed, however, that these drugs are not very effective as monotherapy. Therefore, they should be viewed only as adjuncts to benzodiazepines, not as substitutes. Which leads us to drugs to maintain abstinence. After a detoxification has been accomplished, the goal is to prevent or at least minimize future drinking. The ideal goal is complete abstinence. However, if drinking must resume, keeping it to a minimum is still beneficial because doing so will reduce alcohol-related morbidity. In the trial of drugs used to maintain abstinence, several parameters are used to measure efficacy. These include the following: proportions of patients who maintain complete abstinence, days to relapse, number of drinking days, and number of drinks per drinking day. Again, in the United States, only 3 drugs, disulfiram, naltrexone, and acamprosate, are approved for maintaining abstinence. Disulfiram works by causing an unpleasant reaction if alcohol is consumed. Naltrexone blocks the pleasurable effects of alcohol and decreases its craving. Acamprosate reduces some of the unpleasant feelings brought on by the alcohol abstinence. Of the 3 drugs, naltrexone appears most effective. However, even with this agent, benefits are only considered modest. Owing to the risk for relapse, prolonged treatment is needed. The minimal duration is at least 3 months. However, continuing for a year or more is not unreasonable. If the first drug fails, clinicians often should try a different one. Which brings us to the disulfiram aversion therapy. Its therapeutic effect. Disulfiram, or antabuse, helps alcoholics avoid drinking by causing unpleasant effects if alcohol is ingested. Disulfiram has no application outside of its treatment of alcoholism. Although disulfiram has been employed for decades, its efficacy is only moderate. In clinical trials, there is emerging evidence that the drug may be only slightly better than a placebo at maintaining a long-term abstinence. Again, however, long-term studies have not been completed. Disulfiram does decrease the frequency of drinking after a relapse has occurred, presumably because of the unpleasant reaction that the patient is now familiar with. Supervised administration of disulfiram may be more effective than when a patient self-administers the medication. Mechanism of action. Disulfiram disrupts alcohol metabolism by causing irreversible inhibition of aldehyde dehydrogenase, the enzyme that converts acetaldehyde to acetic acid. As a result, If alcohol is ingested, acetaldehyde will accumulate to a toxic level, which produces unpleasant and potentially harmful effects. Its pharmacologic effects. The constellation of effects caused by alcohol plus disulfiram is referred to as acetaldehyde syndrome, a potentially dangerous event. In mild form, the syndrome manifests as nausea, copious vomiting, flushing, palpitations, headaches, sweating, thirst, chest pain, weakness, blurred vision, and hypotension. Blood pressure may ultimately decline to shock levels. This reaction may last from 30 minutes to several hours. Can be brought on by consuming as little as 7 milliliters of alcohol. In the most severe manifestation, however, acetaldehyde syndrome is life-threatening. Possible reactions include marked respiratory depression, cardiovascular collapse, cardiac dysrhythmias, myocardial infarctions, acute congestive heart failure, convulsions, and possibly death. Clearly, the acetaldehyde syndrome is not simply unpleasant. This syndrome can be extremely hazardous and must be avoided. In the absence of alcohol, disulfiram rarely causes significant effects whatsoever. Drowsiness and skin eruptions may occur during the initial use, but even those diminish over time. Patient selection. Owing to the severity of acetaldehyde syndrome, candidates must be carefully chosen. Alcoholics who lack the determination to stop drinking should not receive disulfiram. In other words, disulfiram must not be administered to an alcoholic who is likely to attempt drinking while undergoing treatment. So there is a patient education portion to this. Patient education is an extremely important component to this therapy. Patients must be thoroughly informed about the potential hazards of treatment, including the severe and potential fatal reactions. Patients should be made aware that the effects of disulfiram will persist for 2 weeks after the last dose, and therefore continued abstinence from all sources of alcohol is necessary. This would include your cough syrups and alcohol applied to the skin after shaving, and colognes. Individuals who do use disulfiram should be encouraged to carry identification indicating the status. It also has a black box warning. Disulfiram should never be administered to a patient experiencing alcohol intoxication because this can potentially cause a fatal reaction. So, its preparation, dosage, and administration, it has a following table, and I'll let you pause and you can kind of review them for all of the following drugs: disulfiram, naltrexone, naltrexone, and acamprose. So, if we're speaking specifically on naltrexone or Revia, which is a pure opioid antagonist that decreases cravings for alcohol and blocks alcohol reinforcing effects. Alcohol report that naltrexone decreases their high, although the mechanism underlying these effects is uncertain. One possibility is the blockade of dopamine release secondary to blockade of opioid receptors. Naltrexone is generally well tolerated. Nausea is the most common adverse effect, followed by headache, anxiety, and sedation. Because naltrexone is an opioid antagonist, the drug will precipitate withdrawal if given to a patient who is opioid dependent. Conversely, if a patient taking naltrexone needs emergency treatment with an opioid analgesic, high doses of opioids will be required. Naltrexone was approved for alcoholism on the basis of randomized clinical trials that combine extensive counseling along with the drug. In these trials, naltrexone cut the relapse rate by 50%. Compared with patients taking a placebo, those taking naltrexone reported less craving for alcohol, fewer days drinking, fewer drinks per occasion, and a reduced severity of alcohol-related problems. In contrast to the original trials, a more recent trial conducted in the US Department of Veteran Affairs failed to show any benefit of naltrexone in maintaining abstinence. So, why did naltrexone work in the original trials but not in the more recent one? The most likely reason is that the subjects in the two trials were very different. The alcoholic veterans suffered from long-term alcoholism, had little or no social support, and received minimal counseling during the trial, whereas subjects in the earlier trial were younger, had good support systems, and received extensive counseling along with the naltrexone. Therefore, a new study does not prove that naltrexone doesn't work. Rather, it only proves that naltrexone doesn't work for all drinkers and doesn't work in the absence of adequate counseling. The basic pharmacology of naltrexone is discussed in Chapter 22. Which brings us to the other side, acamprosate. Acamprosate, or Camprel, is approved for maintaining abstinence in patients with alcohol dependence after detoxification. Benefits derived from reducing unpleasant feelings brought on by abstinence. This effect contrasts the effects of disulfiram and naltrexone. Acamprosate should be used only as part of a comprehensive management program that includes a psychosocial support. In the clinical trials, acamprosate was moderately effective, compared with patients who were taking a placebo. Those taking acamprosate abstained from their first drink longer, had greater rates of complete abstinence, and were abstinent for more total days. Benefits may be related to the degree of alcohol dependence. The greater the dependence, the more likely that the medication will help. Among patients who lacked psychosocial support, little or no benefit was seen. So, its mechanism of action, just how does it work? Well, it's still technically considered unknown. One theory suggests that the acamprosate enhances inhibitory neurotransmission and suppresses excitatory neurotransmission, and therefore restores a balance between neurotransmitter systems. When given to alcohol-dependent animals, the drug reduced voluntary alcohol intake. It also devoid of direct anxiolytic, anticonvulsant, and antidepressant activity, and does not cause any kind of alcohol aversion. So its pharmacokinetics. Acamprosate is administered orally, and the bioavailability is only considered low at 11%. Food reduces absorption even further. The drug, however, does have a long half-life of 20 to 33 hours, and therefore about 5 days is required for plasma levels to reach plateau. Acamprosate does not undergo metabolism and is excreted entirely unchanged in the urine. Adverse effects, however, are generally well tolerated. With most adverse effects, the incidence is no greater than compared with a placebo. The principal exception is that diarrhea will occur in 17% of medicated users, compared to the 10% of those who took a placebo. Reports of suicide-related events, suicide ideation, suicide attempts, and completed suicide are rare but more common than with a placebo. Acamprosate can cause fetal malformations in animals at doses close to those used by humans. Accordingly, it would seem that prudent to avoid this drug during pregnancy, especially because alternatives are available. Acamprosate has no potential for dependence or abuse and appears devoid of significant drug interactions. And that completes Chapter 31. I thank you all for listening as always, and I'll see you in Chapter 32. Till then, thank you and goodbye.